Assalamualaikum warahmatullahi wabarakatuh. So today we're going to do an examination of the liver. The most important aspect is to look for stigmata of chronic liver disease, A, and B, it is to look for signs of decompensation. Number 3, we need to have a look at the possible underlying cause. First, it is important to have a general inspection to look for all of these three things. Alright, three big things that we are looking for in patient with liver. If we're suspecting a liver case, liver presentation such as jaundice or bleeding, okay. Right, general inspection, and we will do the vitals, which will give us an indication of infective cause or not, and B, if the patient is currently stable or not. And I'm not going to mention too much about that. And moving on to the signs of chronic liver disease, moving on to the fingers, we will have a look for any clubbing, for any bulging, which is clubbing, for any spooning, which is anemia, and any change in color, whitish, which we call leukopenia. Then we're going to feel the patient's palm, and then before feel, we're going to have a look. Since the patient we are already seeing the back of the patient's hand, ask the patient to do the hepatic flap to look for, specifically to look for signs of decompensation. Okay, and at the finger, we're not, and turn around, we're going to have a look at the palmar erythema and also the Dupuytren contracture, palpate for any Dupuytren contracture. Okay, these are all signs of chronic liver disease. As a matter of fact, Dupuytren contracture can also be an indicative of chronic alcohol use as an underlying cause, which means that it is alcoholic fatty liver disease, right? So at each part of our examination, we're going to be asking ourselves those three questions, which is look for signs of chronic liver disease, look for signs of decompensation, and look for the underlying cause. So before proceeding, so moving on to the before proceeding further up, at the hands area, we're going to look for any sites of IV recreational drug use. So these are signs of, this is number 3, which is the underlying cause, which would point to viral bloodborne infections lah. Moving on to the face, we're going to have a look at the eye, Kaiser ring, which is signs of Wilson, right? And then obviously we're going to look for pallor. And that's about it, to be honest. At the face, there's not much. And then just gonna ask the patient kindly to expose the abdomen and chest, and ask the patient to lie down flat on the bed. Okay, patient to lie down flat on the bed. Ask patient to lie down flat. Make sure the bed is flat. Okay, so before I proceed, before I forget, on top of looking for the Kaiser, since there are no Kaiser ring for Wilson, we should also feel for parotid, indication of alcoholic use lah, chronic alcohol use. As the patient is now currently exposed, you can see him. Since there's an adequate exposure, we should look for, first start with the general inspection. Any signs of chronic liver disease? So on the chest, look for gynecomastia. Ask the patient to lift his or her armpits to see for any hair loss. Right, and we could also look for any palpate for any testicular atrophy, but there is a bit sensitive, and perhaps that would be the last thing lah. We want to make sure we complete all the abdomen first, and also we need to look for signs of malignancy. B, which is signs of decompensation, which is any ascites or any enlarged abdomen lah, distended abdomen. This is before we palpate. Okay, just have a look. And part 3 of inspection, which is underlying cause. Look for any IV drug use, previous cardiac scar, which give us an indicator that it could be due to CCF, congestive cardiac failure, causing the congestion of the liver. Okay, and also cachexia is important to, especially if it is malignancy we're suspecting. And another one would be pigmentation lah, such as hemochromatosis, if you're suspecting that. And also, sorry, before I forget, the face xanthelasma, which is signs of, in terms of face and body habitus. It could be metabolic, so it could be due to primary biliary cirrhosis, or it could also be non-alcoholic fatty liver disease. Okay, as an underlying cause as well. Moving on to palpation, right? Once we have, that would give us a lot of time to think. Would give us a large bulk of the clues is already been there. So we're gonna have a look at the inspection, right? Another stigmata of chronic liver disease. Well, hepatomegaly may or may not be a stigmata, to be honest, because it could be shrunken as well, so never mind. Before we proceed further, we look for any caput medusa, which is an important hypertension lah, which is portal hypertension. Okay, right, so not really sure how to classify portal hypertension, but I think it is it's a complication from the cirrhosis itself. Okay, but it's not quite decompensation. So we're going to palpate nicely, palpate the liver. Start from the right iliac fossa, where it is nice and soft, and palpate our way up to the liver at the angle of the right costal margin. And once we reach the lower border of the liver, what I need to do is I need to use my left hand and measure the size of the liver, how many finger breath, right? On top of that, use my left hand also to feel for the consistency of the liver, because if it is not smooth, it could be or if it is nodular, it could be cancer or malignancy, and it could also be things such as cirrhosis, when it's fibrotic, and if it's fluctuant, and it could be due to the backflow from the cardiac itself, CCF. Okay, that's one to make sure. And don't forget to percuss as well, because there would be a significant difference between mass and an empty stomach, provided that there's no ascites, of course. So just percuss as well, and feel for and listen for the difference in the sound. And then we will feel for the spleen, right? The technique my prof taught me was, if you can't feel for the brief, ask the patient to tilt, right? Then press the back, and once the patient is tilted towards us, press from the back behind and feel using our right hand. And then same, feel for the size using our finger breath. Okay, and again percuss, right? And don't forget number 3, which is looking for signs of decompensation, which is very important to look for. Shifting dullness, we can do a fluid trill, or we can do a shifting dullness test, right? There will be when we percuss, it will be hyper-resonant, and when we go to the side, it will be dull, and when we ask the patient to tilt and wait 30 seconds, and if there is a positive shifting dullness, then when we percuss, it will be resonant, and when we percuss down, it will be dull, and this is a positive sign. So in this case, if there's ascites present, this means that there is signs of decompensation as well. Okay, right, so let's not forget to auscultate for the bowel, right? Especially liver, from what I read, there could be some broods if it is a hepatocellular but ausculting for the liver is not taught in our medical school, so we will leave that for now. Just a complete examination, we will also auscultate for the abdomen lah. When and before I forget further, we also need to look for any signs of bleeding and anemic, which is another sign of decompensated liver, and for any purpura. Okay, and if the patient seems confused, that itself is also signs of encephalopathy, but we already screened for encephalopathy with the hysteresis flap. Lastly, look for any edema. Okay, and with that, I will kindly tell the patient that the examination has been completed and the patient can get dressed up. Thank you.